All right, welcome to Season 2, Episode 10 of the Six Lessons Podcast. We're very excited to have you join us, and we hope that everybody's enjoyed the 2 seasons so far. We wish everyone to get to the highest level of knowledge of the 6 lessons approach. This biomimetic restorative dentistry is gaining traction all over the world. We're getting contacts every day for more interests from more countries, and we know that you'll enjoy being able to implement these as you find mentors and deep dive into the literature. This episode will be a follow-up of the last episode, which was on occlusion, and the general introduction to occlusion in the 6 lessons is prioritized as the 6th most important thing. Now, in the 6 lessons, all lessons are important, but the 6th lesson, which we will deal with in a little more detail today, has to be founded on the first 5 lessons to have long-lasting, pain-free restorative dentistry. So we want you to become masters of lesson 1 before you become masters of lesson 2, and lesson 2 before 3, 3 before 4, 4 before 5, 5 before 6. My mentor in occlusion was John Coyce. I studied for a year with John Coyce in 1998. We went through 2 notebooks, and these notebooks were chock-filled of references and illustrations and concepts. And of course, if 1 lesson fills 2 notebooks, 6 lessons fills 200 notebooks. And when we published the 2012 article, John Coyce personally reached out to me and thanked me for that important contribution to restorative dentistry, because caries detection and caries diagnosis and treatment of deep caries, which we dealt with in detail in the 2012 article that I wrote with Pascal Magne, John Coyce recognized it immediately as a very important contribution to that important aspect of restorative dentistry. But as we go through each of the lessons contribute questions that need to be answered. And for example, in lesson 6, when we talk about occlusal forces, how does that manifest? In lesson 2, we talk about cracks and the cracks and gaps that are manifestation of stress to the tooth or the tooth restoration complex. And so in lesson 2, we specifically talk about dealing with diagnosis of cracks and gaps and treatment of restoration so they have no gaps and no cracks in the part of the tooth that's holding the restoration side to side, front to back, and top to bottom, which we call the peripheral seal zone. But in lesson 6, if we have everything perfect as far as reconstructing the tooth, but we don't have the occlusal anatomy and the occlusal scheme quite perfect, then we have stresses into the tooth that are distributed in a non-ideal way. An ideal way of stress distribution was first published in 2002 by Belser and Pascal Magne, and it showed that a verticalization of occlusion always distributes the stress throughout the tooth without concentrating stresses in certain area. But that same article showed that if you had a 1-point contact on a sliding incline from a cusp, if you have a cusp and an incline and you have a contact here, all of a sudden the tooth is being torqued instead of compressed. If we have the contact in the fossa, then the compression is distributed throughout the whole tooth. Well, the manifestation of these stresses can be, as we said, cracks into enamel, cracks into dentin, and restorations that fail. But this idea of verticalize the occlusion, what if we don't verticalize the occlusion? How many patients come in with a verticalized occlusion where the teeth are in their ideal compression? Well, just a rough estimate would be 50%. And 50% of the patients that come in with a normal cusp-fossa relationship and anterior guidance, where the cuspids are helping the mandible know where to go and go up and down like a rat or a dog, and not sideways like a cow. And so these concepts of a lateral envelope of function, John Coyce taught that as chewing like a cow, and that causes more stress on the tooth and the tooth restoration complex. And so if we don't verticalize the occlusion with anterior guidance, and we have what's called group function, where the teeth are more prone to having these sliding contacts on the cuspal inclines, what's the manifestation? Well, the manifestation is abfractions. When I went to dental school, abfractions were still being discussed as multifactorial. They didn't know if it was toothbrush abrasion, you're brushing your teeth too hard, or they didn't know if it was you're drinking acidic sports drinks, that were eroding, or perhaps it was occlusion and this abfraction. Well, the first researcher who did the best accumulation of the data was named Grippo. And Dr. Grippo, publishing his articles, theorized that this group function put more stress and did not have an ideal cusp-phos relationship. The Pankey-Man philosophy that we talked about last lesson had a lot of ways to ideally make a cusp-phos relationship. Usually it was with waxing up gold onlays, a conservative restorative technique. But again, you're talking about 20 or 24 units that might be involved in these gold onlays in this reconstruction in a badly worn dentition. And of course, that's a specialty that a prosthodontist would take on. For a general dentist to take those cases on, you need advanced training. That's why I was trained with John Kois in 98, 99, 2000. I did larger cases and I understood the challenges. And I also came to understand why prosthodontists generally charge 3 times as much as general dentists when you talk about how much a tooth is going to cost to get it restored. If it's a restoration that's just one tooth or two or a quadrant, then you're not changing the occlusion. But the prosthodontist to see worn dentition and TMD, where a joint would be involved, again, they have more diagnosis and usually involves diagnostic wax-ups, temporization, usually several sets of temporaries over a treatment might be involved. So there's a lot involved in a full mouth case, and only those who have done them can really appreciate the challenges. But the abfraction issue, once Grippo identified this and finite elemental analysis like Belser and Magne put forward, were in a clinical trial in vivo, totally validated by Maria Pintado. Now, Maria Pintado is not a name that hardly anyone knows unless they've gone to the University of Minnesota. At the University of Minnesota, they had a whole floor dedicated to dental research. It was the 14th floor. Dave Wald can correct me if it was only the 11th floor. But I visited Moose Tower in Minneapolis, University of Minnesota Dental School, went to the 11th or 14th floor, I can't remember exactly which one it was, and met Maria Pintado. And I had heard the name Maria Pintado from this article, and I also heard it from Pascal Magne, who had spent over a year at Minnesota doing postgraduate research that led to the publication of his first book under the direction of William Douglas. William Douglas headed up the research lab. Ralph DeLong was another important person there. Anthony Verschlush was there for a number of years, just had a top-notch team of dental researchers. And a lot of the research was focused on micromovements in teeth and simulations through 2D and 3D simulators. But when I first read Pascal's book in 2002, the thing I remember the most was that he had some strain gauges. Now, no dentist knows what a strain gauge is unless they've been mentored by somebody who has some connection with engineers. And engineers learn about strain gauges because they know that things fail not from usually big catastrophic events, but from small micro movements that are jiggling the molecules in ways that eventually start cracks. And so these strain gauges that Pascal shows in his 2002 book and his other books that were published a couple years ago show these small movements and how teeth under function make these small movements, and that these small movements, although they're not visible to the naked eye, have an effect on the substructures or the microstructures of a tooth, mainly enamel. So they decided to do an in vivo test and follow it over 3 years. And so the test had a group of patients that had abfractions, and the group was divided into 2 groups. One got no treatment. The evaluation of the occlusion was that it was in group function, did not have cuspid disclusion or cuspid guidance, but the inclines of usually the buccal cusp on the lower and the lingual cusp of the upper are the ones that hit these inclines on the cuspal inclines first. And these teeth manifested these abfractions. Now, the abfractions, once they're there, can be aggravated. There's no enamel covering the dentin. And so, again, erosion, abrasion, acid attack of these dental surfaces now can become increasingly destructive of tooth structure. But Maria Pintado, without restoring these abfractions, measured them with a very sophisticated measuring technique, and then they followed them over 3 years. Half of the group, they restored cuspid guidance. So they added composite to the lingual of the upper cuspids and composite to the buccal of the lower cuspids. They verticalized the occlusion, so now the mandible wasn't moving this horizontal envelope of function, it was moving more up and down, verticalization. Well, the half of the patients that had the cuspid guidance restored to an ideal verticalization of their envelope of function, the abfraction stopped, because after 3 years they measured very specifically how much tooth structure was missing, and the patients had been told not to drink a lot of acid and not to brush hard. They used soft toothbrushes. They tried to control for those other two compounding variables. This top research lab at University of Minnesota, that the main cause, the initiation for sure of the abfraction, was occlusal related. And so the desirability of verticalizing occlusion, which prosthodontists, using non-adhesive techniques for years, knew that their cases held up better if they had this anterior guidance, this cuspid protection. Later on, John Coyce and others, Francesca Vailati, have shown that the anterior guidance, although it may be a little more sensitive, can also, the same function can be happen on molars, on posterior teeth, as long as the brain gets contact from the nerve stimulation of the molars, then it can program the mandible to go up and down even if there are no anterior teeth. So posterior guidance is another piece of science we have now that we didn't have 20 years ago. Phasing treatment is something that is important to realize. If you have a person who really is under the need of restoring occlusal surfaces on 20 teeth, just economically, it's usually not a very easy way to go. I remember the example of Matt Najad. We used to teach together, and Matt Najad was one of Pascal's best students at USC, and he took on his senior year a full mouth case. Now, the full mouth case, of course, posteriorly was being treated biomimetically using Pascal's protocols. Of course, there were anterior cosmetic considerations for the patient. The patient was a dental student. She wanted perfect teeth on the back and the front. But the long and the short of the story is that it's a very time-consuming situation to document and treat this case, but they got it done in a year. But they only had the final restorations on the top. So the patient was happy. She got her veneers, she got her onlays on the back, but on the bottom, they were all temporaries. Now, in a biomimetic approach, your temporization becomes so much more manageable than a traditional crown and bridge approach, because on the bottom you have biobases. And so if your temporary enamel replacements wear over time because of the length of time it takes for treatment, then you might lose some temporaries, but you still have a totally sealed dentin component of your tooth, and the biobase is pain-free. It just doesn't function very well. But like we teach in the 6 lessons, we want to heal the teeth first and then restore function second. So the healing of the pulp is lessons 1 through 4. The restoration of the function are lesson 5 and 6. And so we always put priority on allowing the pulp to heal. And Matt Najad, he did that. But as things happen after graduation, the patient left town. She didn't get finished. You're not going to believe this. She really actually didn't finish the lower arch. Final restoration on all the teeth in the lower for 10 years. So talk about phasing treatment. I believe in an earlier broadcast, I referred to a patient that we had to phase the treatment because he disappeared from the practice for 26 months because he had a brain aneurysm that he had to deal with to try to keep his life going before we got the tops on these 3 onlays that we had taken impressions for, temporized, But then he disappeared from the practice for 26 months and finally came back. Aneurysm had been successfully treated by neurosurgery. And he came back, and the onlays that were composite, fortunately, were on the shelf. We cemented them, quite a bit of occlusal adjustment, but 20 years later, I saw them a couple of weeks ago. They're still doing fine. But this idea of phasing treatment in a traditional approach without immediate dent and sealing, resin coating, it's a problem. Davey and I once taught a course on biomimetics in Tulsa, Oklahoma. And in Tulsa, Oklahoma, there were 10 dentists that we were training. And as we spoke about this difference between a temporization of a biomimetic approach and the temporization on a traditional crown and bridge, where you would prep the tooth, take an impression, and then cement your temporary crown with usually zinc oxide based cement to try to give it some pain relief. We knew that zinc oxide helped the dental tubules seal a little bit, but that was what I learned in dental school. And then during this part of the lecture, one doctor got this really sick look on his face. And I noticed it. I looked at Davey and he kind of noticed it. I said, Brad, you look like you've had experience with this. And he said, oh, my second wife has just got a full mouth temporization by another dentist. She didn't want to come to me to get her teeth done, but she got this other dentist. She's got all these temporary crowns and they're all sensitive. We said, boy, we do feel your pain. Hopefully your wife will trust you enough to at least do immediate and sealing on these teeth that have already been prepped. And of course, once you prep it, you have different biomechanical challenges without a biorim. But the philosophy was used there was called the bioemulation philosophy. Bob Lee championed that, and he was very big into occlusion, very big into cusp-phos relationship, very big into anterior guidance. He was like the ultimate traditional gnathologist, but he did not have a biologic healing approach to the pulps. But unfortunately, it's been documented by endodontists and prosthodontists, high number of root fractures over the years in these post and core endodontically treated teeth with crowns on. Sophie Schwartz is one of the main experts that has published on this, teach from in the 6 lessons. Occlusion, yes, it's important. If you want more details of larger cases, restoration, how to do that, like I say, Francesca Bailati is kind of spearheading that now around the world in her teaching center, prosthodontic occlusion-oriented courses that are based on biomimetic dentistry in Europe. So we always recommend doctors who want to get more information and more techniques and decide whether to do these larger cases based on modifying the occlusion. We recommend Francesca Bailati's course. John Coyce's course is still a good one to take. There's 2 courses, a basic and an advanced occlusion course. You'll learn a lot. Other people like Frank Spear obviously teach a modified situation but has retired. And so Frank Spear is not teaching at the Spear Center now, but there are others that have advanced prosthodontic training. And I believe that almost every person who's studying seriously occlusion now has the idea that going down and forward is ideal. Another one we should mention is Clayton Chan. For decades have been teaching an approach to occlusions based on a little sophisticated diagnostic technology called the Monitor. And again, the Monitor, Jenkelson and his son been teaching that for decades. And when we get the muscles with these TENS machines that are giving small electrical currents into the masseters and then into the temporalis muscles, you'll see that relaxing TENS stimulation, again, brings that jaw down and forward. The down and forward that we use, we like to stabilize that with a doll appliance. John Coyce uses a deprogrammer. The deprogramming that happens with the Monitor usually results in an impression taken in that down and forward place. And then they make a night guard, but the disadvantage of the night guard, it gets you in the right position. But if you do have a joint that is deteriorating from adhesions, it will not solve that problem unless the night guard is worn 24/7, 365. But these, again, the differences, the John Coyce versus Clayton Chan versus Francesca Bailati versus Dave Alleman, there would be 80% agreement, probably 20% options on treatment. Again, There's a lot of pieces to the puzzle. That will probably be our last piece of the occlusal puzzle we'll talk about, but we would invite everyone to join the 6 lessons so they can get all the research that we use in teaching occlusion with the 6 lessons approach. But until next time, we just always say, get bonded first, stay bonded second.